webinar. So I'd like to welcome you to this lunch webinar, which is organized by the Swedish Paediatric Association's Global Health Group. My name is Helena Hildenvall, and I will moderate this session. We plan for some 25 to 30 minutes presentation, and after that you can post your questions. You're also welcome to write your questions in the chat, but we ask you to not interrupt the presentation as Agnes is speaking. And for everyone to know, we will record this presentation. So in case you have a question and you don't want it to appear in the recording that will be posted on our website, please email us so we will know. So let me just admit some other people. There we go. And today we have the honor to introduce Agnes Linnér, who is a neonatologist, and she's also the researcher in the WHO immediate Kangaroo Mother Care study group. And this is kind of a release party because the results from this study, they were published yesterday in New England Journal of Medicine. So we are very happy to hear the results from this multi-center trial. Welcome, Agnes.
Thank you. So as Helena says, I have some fresh results from a study that was published only yesterday in New England Journal of Medicine. And this was a study done by a group, international group, coordinated by WHO. So it's a really nice group work where I and one of my supervisors were in the author group. So this is the address in case you want to read the study later on. So I'll start with a bit of a background and how we designed the study, because the study in itself is very simple. I mean, it's a big and very important study, but it's not complicated like scientifically. So first, some background for you, if there are any in the audience who are not working in neonatology every day. So there are many nuances to this concept. So Kangaroo Mother Care, what is that? Well, it's the concept of being cared for together with your mother, especially if you're a low birth weight baby. And it was actually founded, or so to speak, in Colombia in the late 70s by Dr. Ray. And it was seen as an alternative to the default mode of caring for a newborn baby. And the default mode was incubator care. But where incubators were lacking, Kangaroo Mother Care was seen as a good alternative of keeping babies warm. You can also say kangaroo care because fathers can do it too, obviously. In our setting, we usually talk more about the biggest component of the Kangaroo Mother Care, and that's the skin-to-skin contact. So Kangaroo Mother Care is skin-to-skin contact and the breastfeeding. In our study, we call our intervention iKMC, so immediate Kangaroo Mother Care. And this is just to keep it separate for the Kangaroo Mother Care that we know is beneficial for newborn babies. So iKMC is our new thing. Also, when you're talking about Kangaroo Mother Care in the low income setting, I think you need to have also the zero separation and couplet care concepts in mind, because KMC per se is not the same as zero separation. I mean, you can do zero separation without KMC, but I don't think you can do KMC with separation. So zero separation is where you keep mother and child together as a dyad from the very beginning. And it's something we talk about a lot in the Swedish settings at the moment, I think. Couplet care is where you care for the mother and the child together. So usually if you have a preterm or low birth weight baby, you have a sick mother also to begin with, and then the mother will need care too. And it's important to remember, and I wanted to keep these different names in mind when we talk about what we've done in our study. So Kangaroo Mother Care, again, it's actually well studied, and there is evidence for Kangaroo Mother Care, and we know that it reduces mortality. This Cochrane review says that for low birth weight babies, Kangaroo Mother Care reduces mortality by 40%, and that's excellent. So when we first started talking about Kangaroo Mother Care, we had people saying that, well, it's already studied. We know already everything about Kangaroo Mother Care. So Kangaroo Mother Care is something that you should start with once the neonatal care is done and the baby is stable. So in this systemic review, there's 20-ish studies with Kangaroo Mother Care started on stable babies, and they show that Kangaroo Mother Care in the stable baby will reduce mortality. So that's Kangaroo Mother Care as we know it. And kangaroo units are actually in almost all places all over the world as a kind of step-down unit from neonatal care and as a way of keeping the low birth weight baby growing and getting more stable before transferred home. And that's why also the WHO guidelines, they say that all low birth weight babies, they should be cared for in KMC as soon as they're stable. But then there's also this. So what is this slide showing us? Well, if you're born low birth weight or premature, sometimes I'm using the low birth weight concept and the prematurity concept overlapping, but it's of course different things. You can be low birth weight and growth restricted, but a large proportion of the low birth weight babies in our study were actually preterm too, so that's why sometimes I'm overlapping. But if you die during the neonatal period and you're premature, then when during the neonatal period do you die? Actually, you will die during the first 3 days of life. So if you look at this meta-analysis by Jiva Sankar and Vinod Pol in Delhi, they've shown that during the first 3 days of life, then 75% of all low birth weight babies die, if they die in the newborn period. And that doesn't make sense really to me if you look at the Cochrane review saying that Kangaroo Mother Care reduces mortality, because the denominator will be different. So if you are offered Kangaroo Mother Care when you're stable, then you need to survive to be offered Kangaroo Mother Care. Hence a knowledge gap. So what will happen if you start Kangaroo Mother Care already from birth? That was our question. And I first came up with these thoughts when I was a resident in pediatrics, and I was working in the neonatal unit at Danderyd together with Björn Westrup, who was the head of department at the time. He's now retired from clinical work, but he's very active in the academic world. He worked a lot with NIDCAP. He was the director of the NIDCAP Center, and he did his own research on couplet care. And he was very passionate about the non-separation thing. Also, there was Nils Bergman, who is a public health physician. He was raised in Africa, he's Swedish by origin, but lived in South Africa at the time. And he has his own firm, or how to say, where he's working on neuroscience and improved care for better newborn outcomes. And he's also passionate about Kangaroo Mother Care. So these two men, they had a sort of seed for a protocol called EPISTOS, Early Parent Infant Skin to Skin Study. And I left for a rotation in Tanzania during my time there at Danderyd's neonatal unit. And when I come back, I suddenly liked to talk to Björn a lot about this concept, because I'd seen the neonatal unit in Muimbili, and I started to think a lot about what could be done there. We applied for grants and we tried to get some, money to realize our project, but it was very difficult because KMC was already evidence-based and everyone knew already everything about it. So people just discouraged us and said that, well, this is not very hot. It's kind of 70s, 80s research. The EPISTOS study had lots of different outcomes. So it looked at mortality, but also like temperature, differences in microbiota in the kids, heart rate variability, and the EEG. It was a very complex protocol, actually. But then, we struggled and we tried to get grants. And Nils and I was at the conference in Rwanda, and there we met with a neonatologist from the Bill and Melinda Gates Foundation, and we started talking a bit more. And then all of a sudden they replied to one of Björn's emails and said that, but okay, you will have a planning grant. and you can like elaborate on your plans. I think you need to elaborate a lot on your plans, and you need to drop the EEG and the heart rate variability and all the stuff, and you need to just focus on survival. And you need to work with the WHO. But please just elaborate on your plans and get back to us, and we'll see what we can do. Which was great, because we had only gotten like negative answers and feedback before. So then a couple of years followed where we traveled a lot and looked at study sites and met with researchers and tried to define what we actually wanted to do. So we wanted sites where there were high rates of low birth weight babies and also high mortality rates, preferably like an academic center where there was some experience of doing clinical trials. Also, preferably a referral center, because any findings that we would get, then we would like to be able to spread them once the results were done. I will tell you later on which sites we decided on, but there were sites in Africa to begin with, and then a site in India was added. So we traveled in 2014-15 and looked at hospital registers and found that the mortality in the sites we were interested in at the time was around 30%, 25-30% in the weight group we were looking for. Also, we saw that the neonatal care was okay, but there were things that could be done to improve it. So we thought that, or actually WHO said that before doing a study on skin to skin, you need to also like lift the basic neonatal care to a better level, which I will also show you exactly what we did with that later on. So we hypothesized that by training the staff in neonatology, we will just by that decrease the mortality from 30 to maybe 20% or something. And then our hypothesis about the skin-to-skin care itself was that maybe an additional 20% mortality reduction by the immediate skin-to-skin intervention. In order to show that, a 20% decrease in mortality with a power of 90% and maybe a significance level of 5% and some loss to follow up, maybe 10%, then we found that we would need 2,080 infants per study arm. So that was what we aimed for. And we ended up deciding on a site in India, Safdarjung Hospital, which is the national hospital there in New Delhi, and also the national hospital in Dar es Salaam in Tanzania, and some smaller centers in Blantyre, Malawi, Ile-Ife in Nigeria, and in Kumasi in Ghana. And I'm mentioning the names just because maybe one of you has worked in the settings and it's interesting to know. So these were the 5 sites where we conducted the study, and the authors of the paper also come from these places. What about the neonatal care? When first step was to do trainings in neonatal care, and of course these places, they have so many newborns and they have a great experience already, but sometimes when you come from the outside you see things that you don't see when you're in the middle of things. So Björn Westrup, myself, and a colleague from Norway, Siren Rettedal, we worked with this essential newborn care package that's available from WHO and American Association for Pediatricians, and it basically covered how to assess the newborn child, how to see if a child is ill, so danger signs. We also worked a lot on preventing hypothermia. And since we wanted to do an intervention on skin-to-skin care with sicker, smaller babies, then we talked a lot about safe skin-to-skin care, because it's not evident that skin-to-skin care is always good and safe. You need to make sure that your child has a safe airway and so forth. So we talked about that. Also, we found that in the settings, feeding was usually quite late. So any child with a respiratory distress or any problems, they would not feed the child. So children were fed very little and very late. So we talked about breastfeeding support and cup feeding and gavage feeding and so forth. And of course, hygiene, we talked about too, how to prevent infections. WHO, they also insisted that we provide the sites with CPAPs. Some of the sites, they had CPAPs already, but for those who didn't, then we provided them with the Diamedica CPAPs. Those are really simple bubble CPAPs for the low income setting. And this was for all babies at the site, so not exclusive to like the intervention group, of course. We also made sure that all our study babies had saturation monitors to monitor them. So this was a new thing, a really different thing from the conventional care in the settings before. And what about the PICOs? Well, the population, the newborns we looked at were mainly premature ones, but any infant with a birth weight between 1 and 1.8 kilo we included. And why these weight limits? Well, below 1 kilo, you have a very low chance of surviving in these settings for different reasons. And this made the care not always very active on the small ones, because you have a very low chance to survive if you're below 1 kilo and you can't give surfactant, or you have a very low staff to patient ratio and so forth. So 1 kilo was our lower limit, and the upper limit, we talk about low birth weight babies, and the official limit is 2.5 kilos, but we found that when we traveled, some well babies with birth weights around 2 kilos, they were not even admitted to the NICUs, to the neonatal units. They were just assessed by someone, and if they were well, then they were taken home with their mothers. So we couldn't possibly admit any extra infants to the NICUs in these congested, crowded settings where we were. So 1.8 kilo was a compromise below which most people said that, well, those children will be admitted to the NICU in the first place. The intervention was skin-to-skin contact from the beginning, from birth and until stable, because once stable, remember that all infants, they should have Kangaroo Mother Care. So the randomization was only for this period when the child would, by conventional care, be separated. We predefined stability criteria together with the colleagues at the sites, and they were basically not needing any respiratory support, so no CPAP, no oxygen, and vital parameters between certain ranges, like respiratory rate, heart rate, so forth, and no need for intravenous fluids or medicines. The control group, the conventional care, it was not exactly the same in all the sites, but the common thing was that the mothers and the children were cared for in separate units. So basically in the NICU, there were no parents except for the feeding times. So mainly mothers and female relatives, they came in 3 hourly or something like that to feed the child, and then they left, and they were first hospitalized in the maternal unit, and then they came from home to take care of their child. And all units, they also started short KMC sessions in the NICU once the child started to recover, and just before they were transferred to the actual Kangaroo Mother Care ward. So the outcome, well, we looked at neonatal survival, so any deaths before day 29, we considered them adverse events, and also that was what we looked at, basically neonatal mortality. And also, since we knew that most deaths occur within the first 3 days, then we also looked at 72-hour mortality. Those were the primary outcomes. And some secondary outcomes, when time to stabilization, so the time it took until you reach the stability criteria. Also the proportion of children with a low temperature, with a low blood sugar, infants with infection, clinical sepsis, and the length of stay, different breastfeeding outcomes, and also the maternal satisfaction with the care and maternal depression according to a score. So that's the study just in 4 bullets. We had some exclusion criteria, so young mothers, we couldn't include them for ethical and legal reasons in the settings. Also, if a mother couldn't understand study info, then of course we couldn't include her. If the mom was too ill to start KMC within 3 days, like an eclamptic or unconscious mother, then we didn't include the couplet either, because during the first days we used a lot of surrogates, like aunts and grandmother's female relatives, they did skin-to-skin care for the mother, but we felt that we couldn't ask them to commit for a longer stay, because after all, they needed to take care of the other members of the family and maybe bring meals to the sick mother and so forth. So we figured it was best not to rely on surrogates to a higher extent than that. Triplets were not included either, and any child who did not establish spontaneous breathing within the first hour of life, then we would exclude them too. There was ventilator care in some of the settings, but not very much. So this was not a common situation in our weight group anyway. If the child needed surgery early, then we felt that that was not like working with Kangaroo Mother Care. And since we worked in referral centers and national hospitals, we had some mothers coming from far away, and we needed to exclude those because the neonatal mortality we assessed by going to their homes at day 29. Members of our study team went home to them because most of the families were discharged at this time, and we didn't have resources to travel all of Tanzania or India to look at the mortality, so they needed to be residing quite near. And then we had a more open exclusion criteria saying that any reason not to start the intervention within the first 2 hours of life, then we would not call this immediate Kangaroo Mother Care, and then those would be not included. And all that I've talked about until now is actually published in trials last year. So our study protocol, you can read all the details on how we calculated and stuff there. So this is our flow chart. So we did an antenatal sort of screening to know like forehand which women were at high risk of delivering a small infant. So women with a short fundal height or a low gestation according to ultrasound, or women with anemia, or there were different criteria for the women when we talked to them about the study, if we were expecting that they would deliver a small one. So that was our pre-screening and our pre-consent thing. Many of them gave birth, but not so many of them had finally infants within the weight group. So you can see how fewer and fewer women and infants are in the lower boxes. Finally, about 3,000 women with some more children, because there were twins too. They were randomized to either iKMC or to control care. And you can see there at the lower boxes, 29 days, that about 1,600 children were analyzed per group. And if you remember our power calculations, then I talked about aiming for 2,080 infants per group, and we didn't reach there because we had pre-specified that if at one of the interim analyses we would see that there was a benefit in any of the groups, then we would end recruitment. And in December, January 2019 and 20, then our data safety monitoring board did monitoring at 75% of the recruitment, and they found that there was a benefit in one of the groups with a p-value that was lower than 0.001, and that was our pre-specified termination criteria. So this is our table 1. So this describes which infants I'm talking about. So our mean infant is a 1.5 kilo baby of 32 something gestational weeks, randomized at about half an hour of age, and intervention initiated at about 1 hour for the intervention group. That's not in the table, but it's interesting for you to know what we think is immediate Kangaroo Mother Care. A quarter of the infants were twins, and a little more than a third were delivered by cesarean sections. So there's quite a high rate of cesarean sections. The sites, you can see that most of our infants came from India, because it's a very busy delivery unit there at Safdarjung, and quite a few from Tanzania, and then some more from Ghana and from Malawi and Nigeria. So I think it looks like the randomization worked. The intervention and control groups look sort of the same. And then you have some socioeconomic and mother characteristics there at the bottom. And this was what the intervention looked like. So basically, mothers were admitted to the NICUs together with their child, sometimes with a surrogate coming with the child first. We used carriers. I mean, the carriers are not important really. In these settings, women are used to carrying their children with cloth in many different ways, but this is the carrier we used just to make sure that the mother could eat and use her hands without needing to hold the child, and also to protect a safe airway. So you can see that these babies, they have different sorts of support. Some babies on CPAP, some with intravenous lines, and some women are sitting and some are sleeping in a bed. Down there to the left, you can see twins with a grandmother and a mother. And you can see how the mothers are taking their meals in the NICU, and they are receiving care for themselves. So we defined both what the neonatal care should be and also what the maternal care should be, because the obstetricians, of course, were worried that we admitted mothers to the NICU, but they got their obstetric care there. So both groups received the same medical care. We had the same staff to patient ratio in the intervention and control group, and we had data outcome teams who went to the study babies 4 hours per day and collected vital parameters. So 8 in the morning, 2 in the afternoon, and then 8 in the evening, and during the night they looked at the children. And the settings, they had different solutions for how to do this. Most of the sites, they just took recliners or beds into their NICUs, but the sites in India and in Tanzania, they organized actual maternal infant neonatal couplet care units. So they had a separate room for the intervention babies, and that's also maybe a point for discussion later on. The picture down to the right is from Kumasi in Ghana, and there you can see that they mix. So there's a control baby in an incubator, and then there's an intervention baby in the bed with the mother, both on CPAP. We achieved quite a lot of skin-to-skin care per day, so 17 hours median in the intervention group, and that's a lot, actually, if you know about our skin-to-skin hours in Sweden, for example. Yeah. And now the results. So we've shown that immediate Kangaroo Mother Care for low birth weight infants between 1 and 1.8 kilos in the low and middle income setting reduces mortality by 25%. So that's our great finding. I think it's very important, and it's great actually. So you can see that there in the top, that deaths in the intervention group were fewer than in the control group, and it's a statistical and clinical very significant result. Survival at 72 hours was also different, but it did not reach really statistical significance there. So 23%, but no statistical significance. For the secondary outcomes, I was surprised to see that the breastfeeding rates were not different really. I thought that was probably one of the mechanisms, that if you stay with your mother, you will breastfeed earlier, and that's a good thing. But we couldn't show that actually. We have some post hoc breastfeeding outcomes also in our appendix in case you're interested in that. So you can see that. But hypothermia was important too, and probably one of the mechanisms. So they were significantly less hypothermic in the intervention group. And also they had lower rates of clinical sepsis in the intervention group. And that's shown before also in other studies, but it was anyway interesting to see, because one of the comments we had when we traveled the sites was that, but you can't put the baby with a fresh cord on the mother, they will have a septic cord and they will have sepsis. So they were actually very worried about keeping the low birth weight baby with its own mother for infection control reasons. And that doesn't, I mean, we've proven the opposite actually, that it protects, and probably because then fewer other people will handle the child, and the mother will colonize her child with the good bacteria, sort of. But no differences in the other outcomes like hospital stay, time to stabilization, or maternal satisfaction, not that we could show anyway. And this is another way of looking at the data. So this is a forest plot for those of you who are not used to seeing data like this. So I'll talk you through the picture, but this is our sample in subgroups. You can see different birth weight categories and gestational age categories, a mode of birth like normal vaginal deliveries and C-sections, singletons and twins, if they are small or appropriate for gestational age. And then also, this was not in our actual manuscript from the beginning, but reviewers required that we also separate for the sites. So you can see any differences between the sites there at the bottom. So you can see the vertical line, and anything to the left of the vertical line speaks in favor of the intervention. Anything to the right of the vertical line speaks in favor of control and normal care. And the big black dots is the actual value, and the horizontal line is the confidence interval. And usually we think that if the horizontal line crosses the vertical line, then there may be no difference between the groups, and maybe the results are not significant. But at least to me, it looks like the results are on the left side. So it looks like in all the categories, intervention is better than control for this group of babies in these settings. I'll come back more to the sites because you can see that there's some differences between the sites too. So how to interpret these results then? Well, we did the study together with the WHO. They were coordinators and co-authors, and they actually started already preparing before the publication dates of different materials and started thinking about change of guidelines and so forth. So that's the question. I mean, do these results, are they enough to change global guidelines for newborn care? Should all neonatal units have MNICUs, mother infant care, mother neonatal intensive care units? So should we like replan all the NICUs in the world? Well, maybe we can discuss that later. And now about the differences between the sites. Well, Ghana, what happened there? Seems like more children died there in the intervention group. So how do we do implementation there in case the WHO says we should? Will we kill babies or what? Well, as researchers, we've looked a bit at this already, and Ghana was exceptional in that they had a really late initiation time. So the intervention babies, they received skin to skin quite late, and they had a quite low dose per day. But anyway, should they die to a higher extent, or should it be more like the same? This is very interesting, I think, because maybe there is something about the skin to skin care that's dose dependent. I don't know. We looked at skin to skin doses, and by dose I mean hours per day. And we found, of course, that those who have many hours of skin to skin time per day survive more, and those who have very few hours, they die to a higher extent. But that's probably, reversed causality, that those who are sick, they are not receiving Kangaroo Mother Care because they are subject to interventions and so forth. So I think you can't really draw any conclusions from our results. That's in a table in the supplementary appendix in case you want to see. But India, they had amazing results. So they had a 33% lower mortality in the intervention group. And what did they do especially well there? I think we need to find out more about that. Maybe it's the actual logistics, their mother neonatal intensive care unit, the actual room that they created. I mean, it needs exploring. So now I'm hoping for some implementation steps, scale-up studies to look at this in a higher, at the higher level and in more infants and so forth. Also, of course, we're looking at the secondary outcomes at the moment a bit more, and there's an ongoing follow-up study, because one of the worries in the low-income settings is that we'll produce a lot of handicapped children. So if you survive, then it's also important to know that you survive to a good life, and also that you don't die later on. So there's a follow-up study looking at later in life mortality and also at neurodevelopment until the age of 2. So that'll be interesting once that study is published too. That will probably take 2 years from now then. And also, this study had a lot of attention actually. Yesterday we were on the TV4, Morgonnyheterna, and in Aftonbladet and so forth. And I'm wondering, do these results from the iKMC study, do they have an implication for us as Swedish pediatricians and maybe nurses? We can discuss that more, but my spontaneous answer is maybe not so much, because the comparator is different and our standard neonatal care in Sweden is very good. So I really don't want people to mix up the settings. And I don't want any parents listening to the morning news to think that their child will die in Stockholm because of too little skin-to-skin care, because that's after all very unlikely. But I think we should be more curious about the potential of skin-to-skin care also in the Swedish setting. So we have a study ongoing in Stockholm and Norway, and that's more like, if you remember Björn's and Nils's original idea with lots of different outcomes, looking at physiological transition, epigenetic marks of the early skin-to-skin care, differences in respiratory support and different things. We have an ongoing study looking at that in the high income setting here at Karolinska and also in Stavanger. And it's a much smaller study with very few patients, but if you're interested, then our protocol is also published in BMJ Open last year. So there you can read what we're doing at the moment in Sweden. Yes, that's all. Maybe time for some questions and discussions.
Thank you very, very much, Agnes. It's a really interesting study. So I welcome any questions to Agnes. You can either just put your microphone on and ask your question, or you write your question in the chat. As we're waiting, maybe I can just start with my question. Because I'm curious, you say that you started by, well, you did an essential care intervention for both the controls and the intervention groups. So I'm just curious to know whether you somehow assessed the baseline mortality changes just by doing that.
Yes, but I'm really disappointed that we didn't document what we did, because we found something super interesting. So in our protocol paper, it says that the mortality at baseline in 2015 when we traveled the sites was 32%, and that's by looking at hospital registers for the last couple of months. And it was different. Malawi had a very high mortality rate and India a bit lower, but on average in these 5 sites, 32% mortality. But then actually when the study started, the mortality was already lower. Probably you looked at our control and intervention group, and their mortality in the intervention group was 12% and in the control group 16%, something like that. So I don't know if it's our training or if it's just time. Everything gets better with time, because some years have gone by also. But our feeling is that the training in feeding your child, keeping the child warm, washing your hands did a lot also. And that would be great just to show that too.
Yeah. Yeah, interesting. So I can see that Thomas raised his hand. So please, Thomas.
Thank you very much, Agnes. This was really impressive and so good to see the results. I'm very impressed. What I would like you to tell us more about is that you said that most children die within the first 70 hours of life, but you couldn't see any significant difference after 72 hours. Have you any ideas why it is like that? And also hypothermia as a cause of death. When would you expect the babies to die who are hypotherm after a couple of hours after birth?
That's a good question. So you don't die maybe from hypothermia, but it leads you into a negative, way of getting other problems. Maybe you get hypoglycemic and etc. etc. So probably that's just a piece of the puzzle. No, we were actually surprised. We thought that we would find a higher mortality during the first days, and we looked a lot at maybe are we just deferring like the deaths? Do they die just later on? We keep them alive and then they die, and we looked a lot at the time of deaths too. And I don't have a good answer actually.
Okay, thank you. So some other questions. There's one from Neo Lund to start with. Please go ahead. Neo Lund.
Hello. Yeah, hello. This is Christian Gelsberg from Lund. I'm just wondering the differences between Ghana and India. Did you see any significant changes in socioeconomic status between those countries? And did you adjust for those in the analysis?
Yes, we adjusted for family income and actually all the maternal and infant variables in the table 1, they were adjusted for. So they should be taken care of by adjustment. Okay, and did you see any differences in intellectual abilities between the mothers in those countries? Between India and in Ghana? I can't describe it, but Ghana is poorer than India, and they have a lower. No, to go to school. They are poorer, so I'm sure it contributes. I can't really tell you any numbers about the sickness of the mothers or like socioeconomic factors, but it's definitely a country where the mortality was higher to begin with, and they have a more difficult situation. Och jag tänker också på skillnader i hur många år man har gått i skolan. Precis. Nu switchar jag till svenska bara. Ja, men det är bra. Och jag har inte svaret, för jag vet inte faktiskt exakt om man bryter ner det så. Jag vet bara att vi anpassade det till det. Men det är klart, det kan spela roll. Sannolikt så har de lite lägre utbildningslängd i Ghana. Men jag har inte svaret, tyvärr. Jag kan kolla upp det. Jättebra. Jätteintressant. Tack.
Right, and let's switch back to English since we do have some non-Swedish speaking people in the audience. I think there's one of your co-authors that wants to comment. Björn Westrup, please go ahead.
Hello. I don't know. I'm in the car. Can you hear me?
Yes.
Yes.
I just did a fantastic presentation, Agnes, very truthful and good. Another comment of why it might be a difference between pre-study and pre-recruitment. I surely think that our training in basic neonatal care, as well as the training of KMC in the KMC wards, made a big difference. Because remember that in the control group, they had very high KMC time after stability. And this is not what is commonly performed in other studies. So for the controls, I mean. So I think that could be one of the reasons. And I think also, again, Ghana, in my impression, is that they couldn't really provide mother newborn infant couplet care. They had difficulties of getting the obstetrics on board. So I think it's a lot of logistics there.
Yeah.
Thank you.
Thank you. That's very interesting. So I think we're kind of running out of time, but there's one more hand raised. Susanna Mynnertz, please go ahead with your question.
Yeah, so it's a short question. I mean, and I have quite some years experience from Mulago National Referral Hospital in Uganda, which is of course also a very busy hospital. And I'm wondering a little bit about what you think about the implementation in these kind of like busy hospitals in sub-Saharan Africa, since there are most of the time, I mean, lack of a place to be and people to care for huge needs and maybe lack of saturated, pulse oximeters and so on. So a small comment on that.
That's a very relevant question, and that's what we're thinking about at the moment, because it's one thing knowing something and it's a completely different thing doing it. And that's what some of the sites said to us, that, well, it's lovely, but look at our 200 infants in the NICU. Can you see 200 mothers here? And it's, of course, very difficult. But if you have a result like this, like a 25% mortality reduction, then I think at least you need to explore and see what you can do. I'm thinking the first days in life, the mothers are admitted to the hospital. So obviously they are somewhere. Maybe you can do some sort of rearrangements, you know, of the rooms. So the mothers are in one unit and the infants are in another unit, and maybe you can use the resources differently. That's the only question or answer I have there.
Yeah, maybe just very hard maybe to have some kind of pulse oximeters going on all the children. That will probably...
Yeah, that was actually within our study. We're not suggesting by our study results that there should be saturation monitors for everyone. I mean, that's optimal, but it's not feasible. So that was just for study purposes.
Yeah, okay, thank you so much.
So thank you. I was just removing your slides, Agnes, because I think time is up. People have eaten their food and they need to go back to work and take care of the babies and other stuff. But thank you so much. I think people can probably contact you if they have other questions.
Yes, my email address was there on the last slide. But I think you can Google and find them. It would be great if you're interested, if you keep in contact and we can discuss more.
Yeah, and we will also share the presentation on our website, so they can also find your email address and contact details there. I just wanted to also remind you, everyone, to please get involved with our the global group of the Swedish Paediatric Association. So become a member. We've had quite a number of successful webinars and a lot of other activities. So please join our group. Thank you very much, Agnes, and good luck with all the future studies.
Thanks.